Okay, hey guys. So we're going to do chapter 7, which is airway management. There's a lot to this, so bear with me. I'm going to try to kind of follow the slides. As always, I'll jump around a little bit and try to tell you where notes need to be taken and what's important here. Click through. There we go. So introduction. So two most important life-saving skills. So airway care and rescue breathing are ABCs of life-saving skills. So airway, breathing, circulation. If you haven't yet, I recommend you watch chapter 9, which is assessment, because we talk a little more about airway, breathing, circulation in it. We're going to talk about it in here too also. So anatomy and function of the respiratory system. So it's to maintain life, all humans must have food, water, and oxygen. We know that. So lack of oxygen, even for a few minutes, can result in irreversible damage or death. Main purpose of the respiratory system is to provide oxygen and remove carbon dioxide from the red blood cells. So we are breathing in oxygen. We're feeding our muscles, our tissues, our organs. And we're kicking out that carbon dioxide. So some of the things we kind of need to know here. A little bit of anatomy here is your nasal cavity. Okay, it's right up in here. Your mouth, which we know that is your nasopharynx. Right through here. Your oropharynx, right there. Your pharynx, epiglottis. You're going to see that a lot. It's going to be in test questions. It's going to be, what's the leafy shape in the back of your throat? That's your epiglottis. Your larynx. And then, of course, the top of the lung is the apex. Your trachea. Trachea is right here, or your windpipe, if you will. And that right here that I'm still pointing, that's going to be your voice box. Your bronchioles. Actually, let me back up and go. Trachea, your main bronchioles or bronchus are these right here. Your where V's off or Y is off or however you want to look at it. Where that happens is called the carina, right here. It's where the separation takes place. It goes down. If you look at your lungs as a tree, you've got your branches, which is your bronchioles. That's the branches of your tree. And then that breaks on down here to your alveoli. Okay, these, if you will, are the leaves or the fruit of your tree. So you got your main trunk, you got your main branches, and then you got your smaller branches, and then you got your fruit or leaves on that tree. Down here, you got your diaphragm. We'll talk about here just a little bit in a little more detail. In an unconscious patient lying on his or her back, passage of air through both nose and mouth may be blocked by the tongue. So the tongue is a muscle. It's attached to the lower jaw. If there's a partial blockage, you're going to get a snoring sound when they try to breathe. We're going to talk about processes or procedures to open that airway, when to use them, how to use it. Something to think about here, easy way to think about it is your tongue's a muscle. If you go unconscious, or not you, a patient, whoever is unconscious, what happens when you sleep? What happens when you are unresponsive is every muscle in your body relaxes. So if you're laying on your back and you relax, your muscle or tongue is going to fall to the back of your throat. It causes a blockage. So there's some techniques we can use to move that tongue out of the way and open that airway up. So here, the tongue including the airway. So this right here is your airway that should be open all the way through here, and that tongue is blocking it. Here's an example of that open airway where that tongue is pulled forward and your airway is open. Other parts of the respiratory system, at the back of your throat are two passages, your esophagus and your trachea. There's that epiglottis again. It helps prevent food and water from entering the airway. So it covers up that airway and protects it from letting stuff get into your lungs. Airway divides into bronchi. The lungs are located on either side of the heart. So your heart is, we've always been taught that it's on the left. It's actually center left. It's more centered than most people realize, and your lungs are on either side of that. Other parts of the respiratory system, so smaller airways that break from the bronchi are bronchioles. Those are those little branches of your tree, bronchioles. And at the tiny air sac called alveoli. So, like I said, that's either the fruit or the leaves, however you want to imagine it. The exchange of oxygen and carbon dioxide occur at the alveoli. It's called alveolar ventilation. It actually, yes, the alveoli is the main site, but it actually happens in the capillary bed around that alveoli, which we'll talk about here in a second. The amount of air pulled into your lungs and removed from your lungs in 1 minute is called minute ventilation. That's pretty self-explanatory to me. The air that comes in and out in 1 minute is minute ventilation. So here's some alveoli. These are really cool. I get excited about type of stories. So we're coming down here off of our little branches to our leaves, or our fruit, if you will, to the alveoli. They're little balloons, or these little elastic type sacs that when we breathe in, they expand and they fill up. So you got these capillary beds, which is the blue and red as you see. The capillary beds are just venules. So go with me as I try to explain this. So if you look at the alveoli as a bus station, a bus stop, okay? So you've got oxygen that's coming into the bus stop, and it's getting on that bus to go to work, which is your capillary bed, okay? It's getting on the bus, it's going to work from the bus stop. It's going to feed our tissues, our muscles, our body. And then you've got your carbon dioxide that has been at work in your body. It is getting on the bus at the bus stop and leaving. So you've got oxygen coming to work, you've got carbon dioxide leaving. Your alveoli is that bus stop where that transportation is going to take place. So diffusion is where it diffuses over from the alveoli into the capillary bed. So what's going to happen is it's going to go from all that oxygen's coming in, and it's really crowded in this little confined space. So the carbon dioxide is getting the heck out of there because it doesn't like crowds. It's wanting to leave. So it's high concentration area, and so it's going from a high concentration to a lower concentration. And oxygen's trying to do the same thing. It's going into the body, like carbon dioxide is trying to get out of the body. I know that's kind of confusing. In my brain, it makes sense. Lung consists of soft, spongy tissue with no muscle. Get that embedded. There is no muscle in lung. Movement of air into the lung depends on the movement of the rib cage and diaphragm. When the diaphragm contracts during inhalation, it flattens and moves downward. On exhalation, the diaphragm relaxes and once again becomes a dome shape. Okay, there we go. So I take a deep breath in. Everything, my rib cage kind of opens up. My lungs expand. That's why we puff up like a puffer fish when we take a breath. Even normal breathing, we're opening up, and when we breathe out, we're closing in. We're opening up, we're closing in. So what's happening is the lungs are inflating, the ribs are moving outward. That diaphragm is actually dropping down, which allows that extra space for that expansion. So when I exhale, I go back to my little tiny self. My ribs are coming back in. My lungs are closing up a little bit. They don't flatten out, of course, but they're closing up. And my diaphragm is actually going back to the dome shape. So that extra expansion is gone now, right? Because all of this area right here is taken out. So it doesn't show your heart and stuff, but it sits right there. Um, so this isn't actually empty space. This is all filled up. So that's why we have that flex and that ability to have movement when we breathe. That's why it's important that when we backboard someone, or, when someone's on the ground, we don't want to put pressure on that chest or anywhere around them ribs, because we need them to be able to expand. We cannot constrict that movement or they can't breathe. In a healthy individual, airway automatically stays open. In an injured or seriously ill person, it is not able to protect, they are not able to protect their airway, and it may become blocked. You must take steps to check airway and correct the problem. So I'm going to back up for a second. They're talking about A in the ABCs. A stands for airway. So how do we check that? So we want to check responsiveness. Hey, are you okay? Are you okay? Can you hear me? If you get a response, assume the patient is conscious and has an open airway. So if they are able to respond to you and they are able to speak, then they have an open airway. If there's no response, gently shake the patient's shoulder to repeat your question. Are you okay? Are you okay? If the patient's unresponsive, call 911. Have someone else call 911. You call 911 and put it on speakerphone. Then position the patient by supporting the head and neck and placing the patient on his or her back. We want to quickly scan the patient's chest for breathing and check for a pulse. If the patient has a pulse but is not breathing, you need to correct the airway. So we've called 911. Our phone's beside us on speakerphone. You've got them on their back. What you can do is called the look, listen, feel. So I'm going to put my head down there beside their head. I'm going to look down their chest. I'm watching for chest movement. I'm going to listen for air movement. And I'm also going to feel for air movement as they exhale. I should be able to feel air hitting me. At the same time, I can also, if I want, go ahead on the same side that I'm on. I can also be checking a pulse. So I'm look, listening, feeling. I can be checking a pulse and breathing at the same time. And we want this to happen in under 10 seconds. You can usually do it in about 5 seconds. The more that you learn how to check pulse and you learn how to check for chest movement, you can shorten that time, but never more than 10 seconds. So one of the maneuvers we can use to open that airway is called the head tilt chin lift. And you can see this guy here. Head tilt, he puts firm pressure on the forehead as he tilts the head back gently on the jawbone. What this does is, you remember earlier that picture where the tongue had fallen back and blocked the airway? What this does is you are just pulling that tongue off the back of the airway. That's what this procedure does. That's it. It's that simple. So if you are in class, we will practice this over and over and over and over. You're gonna know how to do head tilt chin lift. Very simple procedure. It's the very first step you should do if someone has a pulse but is not breathing, is we want to open that airway. Now, with that being said, head tilt chin lift is used in non-traumatic patients. If this patient just, was a witness down, they just went down. There's no traumatic event involved in this. They didn't fall and hit their head. They didn't, wasn't in a car wreck, anything like that. Then we can use the head tilt chin lift. The next one, same process. It's a jaw thrust maneuver. This is if there was a traumatic event and we're afraid there might be some spinal cord or neck injuries. I think there's a picture here in a little bit, but we're going to use the jawbone, and we're actually going to pop their jaw open. We're not dislocating their jaw. I can't really demonstrate it on myself. I think there's a picture coming up though. We're going to make sure they're on their back. We're going to place our fingers behind the lower jaw and move the jaw forward. Tilt the head back in a neutral or slight snipping position. Use your thumbs to pull down the lower jaw, opening the airway enough to allow breathing. So I'm hooking on right here in the back of my jaw and I'm popping it forward. And at the same time, I'm using my thumbs and I'm pulling that jaw open. So I disagree with this right here, tilt the head back in a neutral. So this procedure is designed not to move the head. It's designed not to have movement in the neck or spine area. So we are not actually tilting the head. I don't agree with that portion right there. We will practice this in class. Okay, cool. So right here, like I said, he's getting a hold of your jawbone, and then you got your thumbs sitting right here. And it's literally that movement, like I'm pulling that jaw and pushing at the same time, and it cranks that airway open without actually moving the head. It's moving that tongue forward. Once again, all this is doing is moving that tongue off the back of the throat. It's nothing special, but if someone is down, they have a pulse, and there's a traumatic event that caused this, we're going to use the jaw thrust maneuver. Potential blocks include secretion. So this is when we're checking for foreign bodies inside the airway. Secretion such as vomitus, mucus, or blood. Foreign objects such as candy, dirt, food, or dentures or false teeth, even broken off teeth due to fights, car wrecks, whatever. If you find anything in the patient's mouth and it is easily accessible, go ahead and let's sweep it out of there. If you can barely see it in the back of the throat, don't go poking and digging back there, though, okay? Because we can actually push it down further, and we don't want that. If the mouth is clear, consider using an airway device. Let me see where this is going. Okay, so airway devices, we're going to get into that here in a minute. So we're just going to move forward, and we'll talk about some of the airway devices that we can use. So the finger sweeps can be done quickly and require no special equipment except a set of medical gloves. Once again, PPE, right? Suctioning. So suction machines can be helpful in removing secretion, blood, and vomitus. They come in all kinds. This right here is a manual suction device. It's not expensive. It's in a lot of like EMR support kits. Sometimes it'll be in some of your more advanced, so like first aid kits. Insert the end of the suction tip into the patient's mouth, squeeze or pump the hand-powered pump, and it will pull that up out of there. Mechanical suction devices, clean the patient's mouth with your gloved finger. So let's get the bigger stuff if we can with a finger sweep. Turn on the suction device using a rigid tip and remove the rest of the material. Do not suction an adult for more than 15 seconds, child for 10, infant for 5. So right now I'm just going to time out. Those numbers right there are extremely important. You're going to get skill sheets. We're going to learn this. We're going to practice it, but we want to go in with no suction. We are going to suction on the way out, either making circular motions or back and forth motions. We suction on the way out only. And like it says here, no more than 15 seconds on an adult, 10 seconds on a child, or 5 seconds on an infant. Learn those numbers. We're going to hound this in class. Once we get the bigger stuff out, we can switch over to a flexible tip or a French catheter suction to clear out deeper parts of the patient's throat. It's more bendable, it's flexible. Some airways, like our eye gels and stuff, we can actually run it down through the airway, through the airway that we have placed in the patient and suction through it, which we'll talk about that later. So this is like a portable suction. It's battery powered. We keep these on our trucks. Anytime that we have like a cardiac arrest or something and we need suction inside the scene, like a home or a vehicle, we can actually yank these out of the truck and we can do suction away from the unit. For unconscious patients, oh, hang on. Okay. So now we're moving on to maintain the airway. For unconscious patients, continuing holding the head to maintain head tilt, chin lift, orthogonal thrust maneuver. If a patient is breathing adequately, place him or her in the recovery position. So adequate breathing is we have good chest rise and fall. We have a good rate, 12 to 20 breaths per minute for an adult is adequate, but we want that good chest rise and fall. We want it regular. We don't want a loud, noisy breathing. Normal breathing is what we want. If that's the case, then we want the actual recovery position is considered the left side. If they are injured on the left, we can roll them to the right. The main thing is we want to get them on their side. I think there's a picture coming up that kind of shows that, but we do this because if they have a pulse and if they're breathing, they're just unresponsive. We roll them on their side so that if they begin to vomit or they have a lot of secretions, it allows it to pour out of the side of their mouth, if you will. Especially if we're dealing with multiple patients at once. We can get them on their left side. We don't have to worry about them aspirating, and we can be working on someone else at the same time. If a unconscious patient is breathing and has not suffered trauma, place patient in the recovery position, helps keep the airway open, allows secretions to drain, uses gravity to keep that patient's tongue and lower jaw from blocking the airway. So that's the other thing. If you're on your back and you're unconscious, that tongue has a chance of dropping back. If you do vomit, you have a chance of aspirating, which is a whole new set of problems. So if we're in that recovery position, it kind of just keeps everything safer. Okay, here's that picture. So what I want to point out here is you roll this patient over, use their leg, their top leg, and a kickstand. This is just like your bike or motorcycle. You kick that out, and it will hold them. We can also use their arms as an upper kickstand, lay their head on their hand. This just allows them to have that open airway. If something happens, it drains out. This is for someone who has a pulse and has a adequate breathing on their own. So airway adjuncts. So these are the tools we can use if we need to help someone keep an open airway. So they are unable to maintain a patent airway. Now remember, patent means open. So oral airways, there's two primary purposes. It's maintain the airway, functions as a pathway for suctioning. Used for an unconscious patient who are breathing, are in respiratory arrest, do not have a gag reflex. So I need to push that a little bit. So if you put a oral airway, and oral is mouth, right? So if you put an oral airway in and they gag, you must remove it. You can't just keep putting it in there and go, oh, I'm going to use a smaller size, which we're going to talk about sizing them here in a minute. But if they start gagging, you have got to find a different route. So this is an oral airway or an OPA. It can be used with mechanical breathing devices. If we're going to be BVMing, bagging someone, we play out one of these. We're going to head tilt, chin lift, or jaw thrust. We can insert one of these that keeps that airway open for us. Select the proper size by measuring the earlobe to the corner of the mouth. So oral is mouth. So we're going to go corner to earlobe. That right there is the OPA size for me. So I would actually take this measurement and I would hold it up against my oral airways until I found one that fit. That would be my size. All these are doing. These are not magical tools. These are literally holding that tongue from falling backwards. That's it. It gives you an open airway by holding that tongue. These here are nasal airways or MPAs. So I tried the oral, and they gagged on me. I can remove it. Most generally, I can go with an NPA. The contraindication or the times when you cannot use this is if you have facial or head trauma, you cannot use these. Um, that's super important to know and understand. If there's facial or head trauma, we are not putting these in the nasal cavity. You can use these in both unconscious and conscious patients who are unable to maintain an open airway. Not as likely to cause vomiting, okay, because we're not touching that little dangly thing in the back of your throat. You cannot suction through a nasal airway. So if you remember that picture where the tongue was in the back of the throat that I showed you, so this is going through your nasal passages, up, around, and it's going right behind that tongue, and giving us an airway, okay? So while we're here, you notice that all these have this little sideways coming in. This is called a bevel. So these bevels are going to face the septum. That bevel goes up against the septum, which is the middle part between your two nostrils. So we lube this up a little. It goes against that, which is usually your right. Your right nostril is naturally just a hair bigger than your left. You insert, it should slide in pretty easy. If it doesn't, you can give a little bit of a twist and usually it'll go ahead and pass. You don't want to sit here and jam it. Sometimes they have a deviated septum up in there and it just won't work. They should slide through pretty simple. It can be used, like it says, conscious, unconscious. If you need to do an airway on a child, sometimes these are more acceptable because they don't tickle the throat. They don't cause gagging. Just a second tool that we have available. So the proper size these is earlobe to the patient's nose. So oral airway was mouth to earlobe. Okay. This is a nasal airway. So it's nose to earlobe. Pretty self-explanatory right there. It's, coat airway with some water soluble lubricant. Airway is fully inserted until the flange or the trumpet, which is that right there, that flange, is up against the nostril. It will stop it from going too deep. So right up against there, and then we stop. And then your book says follow skill 7.3 to insert. I explained it goes against the septum. It slides in. Once you're at that trumpet or that flange, then we can begin ventilation. So B, we've moved out of A, airway. Now we're at B, which is breathing. You can use look, listen, and feel technique to assess adequate breathing. Look for the rise and fall of the chest. Listen for sounds of air into and out of the patient's mouth and nose. Feel for air movement on your face. And like I said earlier, it doesn't say this, but you can also check for pulse at the same time. Normal adults have a resting breathing rate of 12 to 20, which we kind of talked about. You do need to know those numbers. 12 to 20 is an important number to know. Noisy respirations, wheezing, or gargling are signs of inadequate breathing. Rapid or gasping respirations. Signs like pale skin or blue skin, which is cyanosis, means blue skin. Most critical sign is respiratory arrest, which is characterized by lack of chest movement, lack of breath sounds, lack of air against the side of your face. If they're not breathing, we are looking at respiratory arrest. Okay, we're in deep trouble at that point. Causes of respiratory arrest, that's heart attacks, mechanical blockage or obstruction caused by the tongue or foreign objects, vomitus, particularly in patients weakened by a condition such as a stroke, because they don't have the ability to get that out. Foreign objects, I said, and that can be anywhere from a Lego to a piece of steak, a hot dog, a quarter, anything that someone can put in their mouth can be a foreign object. And then illnesses and diseases. I think it talks about here in a minute, but also swelling, anaphylactic shock. can play into that. Causes of respiratory arrest, drug overdose, poisoning, severe loss of blood, electrocution by electrical current or lightning. Assessment of any motionless patient begins by checking for responsiveness and signs of breathing. This is why I said go ahead and go look at chapter 9 video, because we talk about assessing the patient and the steps we take in doing that responsiveness check and how to do it. It's called AVPU, alert, verbal, painful, or unresponsive stimuli. Check out chapter 9. If the patient is unresponsive or unconscious, quickly scan the chest to see if the patient's breathing. Once again, we are never checking more than 10 seconds. So, correcting the breathing, as you perform rescue breathing, keep the patient's airway open. That's that head tilt chin lift. That's the use of those adjuncts, that OPA or that NPA. You can pinch the nose, take a deep breath, and blow slowly into the mouth for 1 second. So we're pinching, we can do head tilt chin lift, pinch that nose, 1 second of air, and we're going to do that a couple times. While we're giving that breath, you need to have your eyes looking down that patient and watch that chest rise. We don't want to blow them up like a balloon. It's 1 second. That's it. Make sure that chest rises. If the chest doesn't rise, let's reposition and make sure that airway is open. So remove your mouth, let the lungs deflate, breathe for the patient a second time. After first 2 breaths, breathe once every 6 seconds. I'm going to slip up. I'm going to tell you right now. I was taught it's once every 5 to 6 seconds. So 5 to 6 seconds is what we're looking for. This book says 6 seconds. If you do the math, that's going to come out between 12 and 20 breaths per minute. Mouth to mask rescue breathing. It enables you to perform rescue breaths without mouth to mouth contact, reduce the risk of transmitting infectious diseases. To use mouth to mask ventilations, follow the skills in your book at 7.4. So guys, there's a picture coming up. I'll talk more in detail when we can actually see the picture, but you're going to use these. You're going to use what's called the EC technique. And it ensures that you have a nice tight seal. That's really important to remember, that you need a tight seal so that breath you're giving is making it into the airway and it's not leaking out the sides of that mask. What's cool about these is it has a one-way valve, so air can go in, but nothing can come out. And when I say nothing, I mean their nasty breath. I mean their vomit. Anything that comes out of them can't get to you because of that one-way valve. Mouth to barrier rescue breathing. Its devices are small enough to carry in your pocket. You've probably seen these. It looks like a piece of saran wrap with a valve on it. You lay it over their face. It has a valve right where your mouth goes. Essentially the same thing. Got that little one-way valve in it. You blow in, nothing is supposed to be able to come out. It's just a protective shield so that you can avoid mouth to mouth, which we'll talk about that a little more in detail when we do CPR at chapter, 8, I think it's the next chapter, I'm not sure. Mouth to mouth rescue breathing requires no equipment, carries a somewhat higher risk of contracting a disease. Once again, if you choose to give mouth to mouth, we're going to head tilt chin lift, we're going to pinch that nose, we're going to seal our mouth around their mouth. We got to have a good seal, and you're going to give that 1 second breath, wait, give that second breath, make sure that chest does rise and fall. Mouth to mask device, place the mask over the face of the patient and make a tight seal. Squeezing the, bag mask device, my bad. Squeeze the bag, pushes air through the one-way valve, through the mask and into the patient's mouth and nose. As the patient exhales, a second one-way valve releases that air. We're going to practice with BVMs in class as well. I don't want to go deep into detail because we're going to do it in class, but the BVM is pretty good around. Okay. I don't know the exact numbers. I know that other people know them, but I don't off the top of my head. We are not just compressing that bag all the way. We're not just hammering down on these people. Um, we are going to, it's about a quarter to half, and we're going to give that breath. Um, if we're just doing rescue breaths, we're going to give that breath once every 5 to 6 seconds. I'm going to tell you right now, you've heard me already say it. We verbalize everything we do in class, in real life. We verbalize it so our partners knows what we're doing, so that our instructors know that what we're doing. So even in real life, I will go 1, 2, 3, 4, 5, and I say it out loud. That way, everybody involved with that call knows exactly what I'm doing at that time. Bag mask device. Specific steps for using a bag mask device are shown in the skills drill. We're going to do it in class. If you're not in class, if you're just following me on YouTube, go ahead and watch some YouTube videos. Go to your local vocational school and ask them if you can use. Go contact your local EMS. The people that do this career are always wanting to teach. That's part of our job as education. So reach out to people and ask for help. Use a bag mask device is best accomplished as a two-person operation. Definitely. It can be done by one, but it's not fun. So I told you we'd go in detail. So here we go. So look here. We've got a C made with a thumb and index finger, and then down here, your middle fingers, pinky finger, whatever, your ring finger, it makes an E. So I've got a C, and then I've got my E. This guy, they're doing a two-person, which is awesome because they've got a nice tight seal. Air is not leaking out of that. He's got his C and his E, both hands. He's putting good pressure down. You notice you use these fingers here to pull back, and we're keeping that airway open. And you, once again, you're communicating with your partner. So if this is me holding this, I'm going to look at my partner who's running the bag and be like, you have good compliance. Is air going in good? We can both watch chest rise and fall. So that's that EC grip that I was talking about. Airway and breathing review. So A and B, airway and breathing, check responsiveness by shouting, are you okay? Can you hear me? Shake the patient's shoulder a little bit. If the patient's unresponsive, activate EMS. Place the patient on his or her back. Quickly scan patient for signs of breathing and check for a pulse using the look, listen, feel technique. If the pulse is present, correct the blocked airway with a head tilt, chin lift, or jaw thrust maneuver. Once again, if it's trauma, we're using jaw thrust. If it's just not trauma, then we're going to go ahead and just use that little head tilt, chin lift procedure. Check the mouth for secretions, vomit, or solid objects. If anything is found, let's get it out. Whatever, whether we're using suction or finger sweep. We don't want to be pushing air in if we are full of vomitus or blood or secretions or whatever. Correct the blocked airway with your finger sweep or suctioning. Maintain airway by holding that open or by using those adjuncts, those oral or nasal airways. Breathing, check the presence of the breathing while determining responsiveness. Correct lack of breathing by performing rescue breaths using a mask, mouth to mask, or mouth to barrier device if available. Rescue breathing for children. Children are small and you will not have to use as much force to open their airways and tilt their heads. Give one rescue breath every 2 to 3 seconds. So we're looking at 20 to 30 breaths per minute. So if you remember correctly, adults is 5 to 6 seconds, one breath, 5 to 6 seconds. A child is 2 to 3 breaths. One breath every 2 to 3 seconds. I'm sorry. You do the math, you get 20 to 30. So when we open these little people's airways. I'm trying to think how can I explain this. So do your index and your thumb. Okay. Let's just pretend that's your adult airway, right? So if you'll cut that down to where your index finger is sitting in that notch, that could be a child or infant's airway. A lot smaller. They're not near as formed. The lungs are not as developed. So if we crank it too far back, we're actually going to kind of cave in that airway a little bit and make it smaller, which we don't want to do. Or if that head is dropped forward, it's going to crimp that airway off. So it's really important that we just get that neutral sniffing position. Something you can do with children or infants, lay a towel, lay a rag, a t-shirt. On infants, I tell people to, even if you use your cell phone, lay it under their shoulder blades and it will naturally give you that sniffing position. Rescue breathing in infants. So I just kind of talked about it. The only difference is an infant, we are not giving 1 second of air. We are just giving a puff. This is extremely important that we watch that chest rise and fall, because it's literally, I had one of my coworkers say, fill your cheeks with air, and that's how much air you give them. So to me, that's a little too much, but we're going to watch that chest. We want it to rise and fall. We don't want it to blow up like a balloon. We just want it to move. That's it. Those lungs are not developed. If we go and try to blow them up, it's like an old balloon or an old rubber band. It's just going to, and now we're in a whole new world of hurt. So we just give the tiniest little breath, just enough to get that chest. Most common airway obstruction is the tongue. That muscle relaxes, falls to the back of the throat. Best technique, jaw thrust for trauma, head tilt chin lift for non-trauma. Food is the most common foreign object to cause obstruction, which we'll talk about choking and how to dislodge that later. Tongue blocking the airway, there's that picture again. Injury. Okay, we've got an injury right here to the throat. Foreign objects, we've got a chunk of steak or Lego or something stuck in there, and it's completely blocking air, cannot get in here. And then we have swelling. That swelling can get bad enough that we start to block off or cave in our trachea and esophagus. It's another bad deal. Ask the patient, are you choking? I said we can talk about choking. I didn't know it was this fast. If the patient can make noises or cough on their own or even talk, we've got a mild obstruction. If the patient cannot speak or cough, we have a complete or a severe obstruction. So here's the deal with the mild obstruction. If it's a foreign object and we've got a mild obstruction and they can cough, stay with them, encourage them to cough. Tell them, I need you to cough as hard as you can. Cough, cough, cough. I truly just had this happen to me a couple days ago. The patient started coughing. I said, I want you to cough like you're trying to cough up a lung. Give me everything you've got. She did it once, and I'll be dang, all of a sudden everything was okay. She's like, oh, that worked. Yeah. So if you get a patient who's able to speak or able to cough, encourage them to cough. And stick with them. If it gets worse and they get to the ability where they cannot cough on their own, then we're going to step in. Right there. Okay. If the patient cannot expel objects, arrange for prompt transport. So if they're coughing and coughing, coughing, nothing's working, it's not helping, you're seeing them get weaker, we need to go ahead and get EMS there so we can get them transported. There are things we can do on the truck to help that. Severe airway obstruction, you're going to get that universal choking sign. Okay, no matter where you're at in the world, if someone's doing this and they're turning bright red or blue, we have a severe choke. They're not making noises. They're not going to be able to cough. We've got poor air exchange taking place or no air exchange. We're going to notice that increased breathing difficulty. They're trying, but nothing's happening. Silence cough, they might be making the motion, but then nothing's happening. Loss of consciousness in 3 to 4 minutes. I'm betting it's sooner than that. Your book says 3 to 4, so go with it. Treatment involves abdominal thrust, which is the exact same thing as the Heimlich maneuver. If you're as old as me, that was what they called it back then. Now it's abdominal thrust. So we're going to take our hand, we're going to tuck our thumb in and make a fist. We're going to place that just under the xiphoid process. So you'll follow your sternum down all the way down. It's hard, hard, hard. As soon as you hit that soft spot, that's where your xiphoid process is. We're going to go just under that. So I've got my thumb, my fist made with my thumb tucked in. I'm going to take my other hand and put it over that, however I need to. I'm going to go under that xiphoid process. I'm behind the patient and I'm going to go in and up. I'm not trying to be their friend. I'm not giving them a hug. I am literally just jacking up on these people, trying to dislodge. So what's taking place inside the body at that time is I'm taking whatever positive pressure they have inside their body, and I am cranking on them, creating a negative pressure, pushing that out. I'm trying to expel that. So what I kind of joke around with in class when I teach this is when I'm doing this, whatever's air's left in them, I want it can come out 2 ways, and I'm wanting it to come out the top way. So we are cranking. The idea is that pressure is going to build up and it's actually going to launch that object out. That's the point of the abdominal thrust. I don't know if it talks about, I'm jumping ahead here. Okay. So if we get a extremely large person, or we get say a pregnant female, we don't want to be cranking on their belly. Or a great big person, I can't get my arms around them because I'm a pretty little guy. I'm going to move up. Instead of hitting that xiphoid process, I'm going to go up a little bit on that chest, and I'm going to do the same thing. I'm creating that pressure inside the body. Hopefully expel that out. Hopefully I'm going to launch that out. So management of an foreign airway obstruction, sorry. Airway obstructions in adults. If the patient's conscious, stand behind them. We talked about that abdominal thrust. Okay, I got ahead of myself. If we do this, when we do those abdominal thrusts, or we moved up on the big guy, the pregnant woman, whatever it might be, and they go unresponsive on us, that 2 to 3 minute window has hit, they go out. We want to try to lower them to the ground as gently as possible. And we're going to begin CPR, chest compressions. We are doing this once again to create that pressure inside the body to force whatever's in there out. Once they're unresponsive, we do chest compressions. In a child, tilt the head back just past the neutral position. If the child becomes unresponsive, let's see. Perform CPR 5 cycles before activating EMS. So I got to teach you that, but I don't agree with it. So if a child becomes unresponsive due to a choking, we're going to do that CPR 5 cycles. Hopefully that dislodges it. We can finger sweep it out of there. I'm going to call EMS either way. Airway obstruction in an infant, if the infant has an audible cry, airway is not completely obstructed. So same as an adult, if they're making a noise, it's not completely blocked. Use a combination of back blows and chest thrust. Compressions is a chest thrust. If an infant becomes unresponsive, ensure the EMS system has been activated. Begin CPR, continue CPR until more advanced EMS personnel arrive. So back thrust. So I'm going to demonstrate this in class, but we are literally going to hold that kid belly down on our arm, or however we need to on our leg, depending on their size. We want them at a little bit of a downward angle, so gravity is on our side. And you're going to go shoulder blades, or maybe a little below, I'm going to call it between the shoulder blades. And we are, once again, not trying to be friends. We are actually going to get in there and win 5 good back thrusts. If that fails, we flip that infant over, and we are going to do 5 compressions, okay? Once again, when we have CPR course, we're going to do this. We're going to practice this. Oxygen equipment. So oxygen is considered a drug or a medication. Um, just throwing that out there. People don't realize that. So oxygen is compressed to 2,000 pounds per square inch or psi and stored in portable cylinders. These cylinders are going to be green. The portable oxygen cylinders used by most EMS systems are either a D or E size. Depending on the flow rate, each cylinder should last about 20 minutes. Pressure regulator or flow meter, that is this piece right here. It will attach to the bottle, and so here in a minute, it's a pin index system. So there's two pins on your regulator, and there's two holes right here, and it will line up. That's how you know that you are using the correct regulator for the correct bottle. It's oxygen. It lines up using the pin index system. A single unit attaches to outlet of the oxygen cylinder can be adjusted to deliver at a rate of 2 to 15 liters per minute. A gasket ensures a tight seal, so it's an O-ring. If you hear me use the term O-ring, it is a gasket. It's where the pressure regulator attaches to the bottle where the opening is, and it creates a seal so that oxygen doesn't leak out, because that oxygen is under high pressure and you don't want a leak. Nasal cannulas and face masks. So ensure oxygen is delivered to the patient and is not lost in air. Nasal cannulas are used to deliver medium concentration of oxygen. The face mask is placed over the patient's nose and mouth to deliver oxygen, and a non-rebreather mask is the most common used by EMRs. It gives you percentages here in just a little bit we'll talk about. So a nasal cannula gives you a certain percentage of oxygen. The face mask is a certain percentage of oxygen, and the non-rebreather a certain percentage. Right now, sitting right here talking to you, I am breathing 21% oxygen in the air. So that's what everyday oxygen level is, 21%. Oxygen actively supports combustion and can quickly turn a small spark into a flame. So all sparks, heat, flames, oil substances must be kept away at all times. Pressure in an oxygen bottle can cause an explosion if it is damaged. Oxygen cylinders should be kept inside sturdy carrying cages. We don't want them to fall over. If that valve on top where you turn them on and off happens to break off of an oxygen bottle, it turns it into a rocket, because there is 2,000 pounds of pressure behind that, which is a ton of pressure, and it will actually launch one of them 150-ton-pound bottles like a bullet across the sky. So we've got to be careful. They need secured at all times. So place the regulator or flow meter over the stem of the oxygen cylinder and line up the pin on the pin index system. Right there's the holes I was talking about. That's where those pins are going to come in and let you know, one, you're using the correct bottle, and two, that you are lined up appropriately. I'm tightening secure, screwed firmly by hand. We don't want to torque it using a tool or anything. We just want to make sure it's good and tight by hand. Turn on the valve, 2 turns counterclockwise to turn it on. So I'm going to stop right there. So when we do our skills, this is one of the skills you have to do. Before you do this right here, we're actually going to go ahead and crack that open, and we blow any debris out of the opening. So if there's dirt or hair or grass or anything there, we just barely, just enough to blow debris out, and then we start this process, and we'll learn our skills when we practice it. So we want to, once we have it hooked up, we want to turn it on, and we're going to check our pressure gauge and regulator flow meter. We want to make sure that we're at 2,000 psi, or that we're at 1,500, whatever it might be. You can turn our flow meter, which is, stay with me here, right here. This is your flow meter. You see the numbers. There's an arrow, either probably right here on top, or a little line that tells you, okay, I'm on 1, 2, I'm on 4. We can turn that to whatever our desired flow rate is. We hook up our oxygen tubing and we place that on our patient. It's once again super important to verbalize what we're doing and we tell the patient what we're doing and why we're doing it. So this is a nasal cannula. It delivers low flow oxygen at 1 to 6 liters per minute, and the concentration is 24 to 44. We don't want to go above 6 liters per minute because that's a lot of air blowing in our nasal passage. If for some reason we are going to have this on them for an extended period of time, we would actually add a humidifier, which just moistens a little bit so we don't dry out those nasal cavities. Adjust the liter flow to 1 to 6 and then apply a cannula to the patient. So I use a nasal cannula a lot of times if my patient is shooting around 93, 92. It talks here in a second, but what we want is 94 or above. So I'll just give them, 2, 4 maybe at the most. And I just bump them up there. I watch on my pulse ox. And we want to keep them above 94 is what we're wanting to do. This here's a non-rebreather mask used to deliver high flow oxygen at 8 to 15. My personal thing, I'm going to tell you that if you put a non-rebreather on, you're at 15. Can deliver concentration of oxygen as high as 90%. So right here, this is called your reservoir bag. Right here inside is this little plastic flap. So we're going to hook this up to our oxygen. We're going to crank to 15, and I'm going to put my fingers over this little flap. And when I do that, this bag is going to air up like a little balloon. Once that is aired up, then I'm going to place my mask on my patient. They are able to breathe in oxygen from the reservoir bag. And when they exhale, you'll see right here and right here are a couple little flaps. So when they breathe in, those flaps seal, so they're getting straight oxygen. And when they exhale, them flaps like open up and let the carbon dioxide out. So we're not non-rebreathing carbon dioxide. So we're getting oxygen, carbon dioxide getting out. A non-rebreather mask should be used for patients who require a higher flow of oxygen, including those experiencing shortness of breath, chest pain, carbon monoxide poisoning, congestive heart failure, signs and symptoms of shock, which we're going to talk about all this in other chapters, but we also want to read our pulse ox. Supplemental oxygen must be used carefully so that your team and your patient remain safe. You will need additional classwork and practice training before you're ready to administer oxygen in an emergency situation. I know that sounds crazy. Everybody's like, well, it's just oxygen, it's just air. It is a medication. You can over-oxygenate people. Here's your pulse ox. So your pulse ox, we've all seen these. It's going to read the amount of oxygen saturation in the red blood cells. It consists of a sensor probe and a monitor. Monitor displays percentage of saturation of patient blood. So right here it says SpO2 98. So this person is at 98% oxygen saturation, and most of them also have your pulse on there. So that's also 89. We have portables that we keep in our jump bag, and then we also have a pulse ox attached to our main monitor in the truck. Anytime we're going to get oxygen, we need to be using a pulse ox because it tells us where we're at. In a healthy patient, oxygen saturations need to be 94 to 100. The pulse ox cannot tell you what is wrong with the patient, but it can help you recognize the patient's having a problem or determine whether the treatment is helping the patient or not. So that once again, if I'm at like 91% and I just want to get them up to 94, I'm going to put them on 1 or 2 liters. And I'm going to watch that pulse ox. I'm going to make sure that it's doing what I want it to. So a pulse ox, it can take up to 2 minutes to actually get an accurate reading. So what you're seeing on that pulse ox is actually probably a minute or two old. So we need to continuously monitor that. So I put it on them and I wait for a few minutes and it jumps up to 96. Well, that's going to tell me, okay, so my oxygen is getting in there. We are perfusing. It's doing what it needs to, but I need to remember that that's actually an old reading that I'm looking at. It's not like right now. Pulse ox has certain limitations, so it will not give an accurate reading if the patient, one, has fingernail polish or dirty fingernails. Sometimes we have to take brand new polish off and make people mad. Alcohol swab, dirty, nasty fingernails off. If they're too cold, it will not read because we're not getting good circulation. Has lost a lot of blood, so we are not actually moving the amount of red blood cells we need to, so we're not going to get an accurate reading. Has experienced carbon monoxide poisoning, and that's because carbon monoxide will actually bond to a red blood cell better than oxygen will. So you will be getting 100% reading when it's actually carbon monoxide attached to that blood cell rather than oxygen. So anytime you think you're doing a carbon monoxide patient, you need to keep in mind that you are probably getting a false reading. There's no machine that can replace a careful patient assessment, though. Once again, chapter 9, patient assessment. There's a lot of things that we can do during that assessment. Check every patient for the presence of a stoma. So rescue breathing with patients with a stoma. If you locate a stoma, keep patient's neck straight. Examine the stoma and clean away any mucus in it. And if there is a breathing tube, remove it. Place your mouth directly over the stoma if you need to give mouth-to-mouth breathing. If it's not working, plug that nose and mouth and blow in the stoma. And watch that chest rise and fall. So a bag mask device or a pocket mask device can be used and will work with these patients. You just need to make sure that you form it and you get a good seal if you're using one of them. Gastric distension. This occurs when air is forced into the stomach instead of the lungs. Too much pressure or too big a breath, which we kind of talked about, will cause this. This will increase the chance that patient vomits. Breathe slowly into the patient's mouth just enough to make the chest rise. We've said that 1,000 times. If we're doing this in a main like emergency, we're going to listen to lung sounds. We're going to make sure the air is going where it needs to, but also we need to make sure that stomach isn't blowing up slowly. Do not remove denture appliances that are firmly attached. They may help keep the patient's mouth full so that you can make a better seal. We've all seen people who don't have their teeth in, their dentures in, and their mouth kind of caves in. So sometimes if they are secured and they're not going anywhere, it's better to leave them in. If they are loose or it's a partial or they're damaged, let's go ahead and take them out. If they're firm, we're good. If they're loose, we don't want to cause a choking hazard. Use jaw thrust maneuver. We've talked about this. Patients lying on the floor and there's possibility that there was some sort of trauma. Jaw thrust maneuver is designed to open the airway by removing the tongue, but not move the neck and spine. When the patient is sitting in a semi-reclining position, approach the patient from the side by leaning in through a window or across the seat. This is talking like a vehicle. When a patient is in a sitting or semi-reclining position, grasp the patient's head with both hands. Put one hand over the patient's chin and over the head, other hand over the back of the patient's head. Maintain a slight upward pressure to support the head and spine. So here we've got a car wreck victim, hand back on the back of the head. So we're supporting that spine, and he is slowly lifting the jaw. All that's doing is opening that airway up. Techniques have several advantages. You do not have to enter the automobile. You can easily monitor the patient's carotid pulse and breathing patterns by using your fingers.
Technique stabilizes the patient's cervical spine at the same time. It opens the patient's airway. So, quick review: after opening the airway of a patient who has a pulse but is unconscious, you should perform a finger sweep, immediately attempt to insert an airway, check for secretions, foreign bodies, or dentures, perform CPR. So we've opened that airway. The patient has a pulse. What do we do? So we want to check for secretions, foreign bodies, and dentures. Is there a reason that they're not breathing? We open that airway. We need to see what's going on in there. We need to clean it if we need to. You should place a patient in their recovery position to prevent the patient from going into respiratory arrest, allow secretions to drain from the mouth, protect the patient's spine from injury, or facilitate administration of supplemental oxygen. So we use the recovery position because they have a pulse and they are breathing. They're just unresponsive. So we put them in that position. Why? To allow secretions to drain, right? Remember, they're on their side. We prop them up with our tripod position or kickstand, if you will. And then pulse ox is used to assess the amount of oxygen saturation in the red blood cells, provide supplemental oxygen to a patient, assess how much oxygen a patient requires, eliminate carbon dioxide from the bloodstream. So we use it to assess the amount of oxygen saturation in the red blood cells. That tells us if we need to give oxygen or not and how much. So assess the amount of oxygen. So guys, we did that pretty quick. That's your respiratory chapter. If you have questions, reach out to me. Once again, I say it every video, get on my YouTube channel. There's a couple in there about respiratory. There's like a 10-minute video about alveoli. If you've got questions, reach out to me. I will see you on the next one.